Right, good morning, everyone. I'm going to just share my screen with you now. So first of all, a very big thank you to the organizers for their kind invitation to attend the CardioEgypt 2021 meeting this year, and congratulations on getting this meeting up and running. I'm going to talk to you today about image-guided intervention. Where are we up to? My name is Dr. Khan. I'm an interventional cardiologist and I work in Birmingham in the United Kingdom. So when we talk about intracoronary imaging, we're essentially talking about two main imaging modalities: intravascular ultrasound and OCT. Now they're both slightly different in terms of how they obtain their imaging. IVUS, of course, uses ultrasound and the reflective properties of ultrasound to gain an image of the coronary vessel. OCT uses infrared light. Now, the advantages of OCT over IVUS is that the resolution is much greater by a factor of 10. The image is also acquired over a very shorter length of time. Where IVUS, however, wins is its ability for tissue penetration. We know that some IVUS probes can image up to 10 millimeters in depth, and also its ability to image despite blood being present within the lumen of the vessel. Now, we know that there are limitations to coronary angiography. This is an example of what appears on the face of it to be a normal coronary artery, but it's only when you put your imaging probe down that you realize that there is quite substantial amount of plaque which is present, concentric plaque on IVUS. Now, there has been many meta-analyses that have been carried out looking at IVUS. I've picked this one out. This was published a few years ago, over 9,000 patients, which is an amalgamation of 6 randomized controlled trials and 9 observational studies. And they've looked at hard endpoints: death, myocardial infarction, target lesion and target vessel revascularization, and stent thrombosis. And in this study, they were able to show significant reduction in MACE despite using second-generation drug-eluting stents. So there are advantages of using IVUS even if you're using modern drug-eluting stents. And of course, this has been borne out in the guidelines. This is the ESC guidelines, which tell us quite clearly that we should be using intracoronary imaging when we're considering stent to patients where we want to try and optimize implantation. We should also be using IVUS, particularly when we want to perform unprotected left main stem lesions. And if you look in the restenosis section, there's also a guidance there of using intracoronary imaging when there has been mechanical problems which have led to restenosis. So this is the image that you can appreciate when you do an IVUS study. You've got the lumen, which is located in the center of the picture here. The media is composed of smooth muscle cells, and these do not reflect ultrasound very well, and usually this will appear black on your ultrasound. And then you've got your deep adventitial layer, which is made up of collagen sheets. Now, when you're performing an IVUS, it's important to be able to demarcate where the media is, because that will be your guidance for where you want to perform your measurements. So I think it's important just to focus on how you would perform your measurements. This is a cross-sectional area of a diseased vessel. So you can see I've marked out the lumen here in orange and the external elastic membrane or the media in the blue. Now, what the software will allow you to do is to work out the area of both the media and also the area of the lumen. When you subtract the two, you can work out a percentage plaque burden. Now, it's important to appreciate that the plaque burden is not the same as area stenosis. Now, why is that important? Why is that important to know how to do that? Because the ultimate trial, which was published a few years ago in China, has shown us that actually if we optimize our stents with IVUS, then we will ensure that we have reduced target vessel failure. And how do you go about optimizing your stent? Well, there are three important things that you need to consider. One is, once you've deployed your stent, is to ensure that you haven't landed in any plaque. So if you've got more than, ideally, less than 30% plaque, 50 if your vessel is particularly diseased and there's no clear landing zone. You want to also ensure that there is no edge dissection, and expansion is particularly important. So when you're expanding out your stent, it's important that you do so so that you improve your minimal stent areas. Now, there are different definitions of what an appropriately expanded stent should be in a coronary artery. In the ultimate trial, they used a cutoff of more than 90% in reference to the distal reference area. There are other studies which have been more aggressive with their minimal stent area recommendations. So the IVUS XPL randomized trial, in which patients were randomized either to angio guided PCI or IVUS guided PCI. In this particular trial, they went for 100% minimal stent area in reference to the distal reference area. And of course, when you're achieving these sorts of values, you can see once again there's a significant reduction in the MACE in patients. Now, when you try and target those high values in terms of your minimal stent area, at 1 year you can see that patients who met those aggressive criteria had a less than 2% primary endpoint event rate. So I just want to illustrate things with a case here. So this is a patient who is awaiting renal transplantation. He had a myocardial perfusion scan as part of his workup, which revealed a large burden of ischemia in the LAD territory. So he came forward for an angiogram, and there are many reasons why you might want to perform IVUS in this particular patient, not least of all because you have very little contrast to play with. His EGFR is only 19. Now, when we perform the IVUS one, you can see that we're just distal to this lesion in the mid-LAD. And as we come back, you can see that there is quite a large burden of plaque of around 70% in this area before the vessel opens up once again after the diagonal comes off here at 6 o'clock. Now, using this case as an illustration case, what we did here for this patient was to identify the proximal landing area. And you can see we've found a place where there is less than 30% plaque burden. We've also identified a distal reference landing area as well. And if you've performed automated pullback, you will be able to measure the distance between those two landing zones. And here in this particular case, we chose a 20mm stent, knowing that the lesion length is just a little short of 19mm. This is the minimal luminal area, which showed a plaque burden of around 66%. So the patient was then treated with a single drug-eluting stent, covering and crossing over the diagonal. And then at this stage, we repeated our IVUS study, and you can see where the minimal stent area now has come up to above our distal reference, which was just over 8mm squared. So we've achieved a minimal stent area of 9.3mm squared here. So this is very good because it means that actually we've expanded our stent adequately. There was no distal or proximal edge dissection. And because we'd used IVUS in this case, we had the added benefit of being able to perform this case with only 20 mils of contrast. The second illustrative case that I have for you today is the use of IVUS in left main stem. We know that it's particularly useful in left main stem disease. So this is an 86-year-old gentleman who presented to us with a non-ST elevation myocardial infarction. He had good LV function on echocardiography. He has comorbid disease with COPD. And essentially, he was found to have triple vessel coronary artery disease on invasive angiography. So his case was discussed at our MDT because of the finding of significant distal left main stem disease. You can see he's got disease running into the proximal LAD and quite a large burden of plaque also involving this circumflex. The right coronary artery was unobstructed. Now, because of his comorbidities, the feeling was that he would be high risk for undergoing coronary artery bypass surgery, particularly concerns around ventilation. So we chose, therefore, to proceed to complex left main stem PCI. We were not envisaging the calcium to be a problem, but you can see on the left panel that we were struggling to get a micro balloon down, therefore we had to switch out to rotablation. This was a 1.5 which was able to rotablate and open up this circumflex. Now, we performed IVUS at the outset here, which established that we were going to need a 2-stent strategy to treat this gentleman, and it also allowed us to size the stents appropriately. So we went ahead and treated with this left main stem with a DK crush procedure using a 3mm stent in the LAD and a 3.5 by 20 stent in the circumflex. Now, there is data for using IVUS in left main stem stenting. The study that I've chosen for you is from Excel. We know that in the Excel trial, about 2/3 of the patients who were randomized to left main PCI actually underwent IVUS, and out of those, a proportion, or a large proportion of those patients had analyzable IVUS data. Now, when you speak to the operators who've performed the procedure, you can see that IVUS does have a big impact in terms of how the procedure is changed. So operators are more comfortable using larger balloons, more aggressive with their post-dilatation, and they're happier to use higher pressure to post-dilate vessels. They also pick up under expansion, and they can treat that appropriately as well at the time. Now, when the 3-year outcome data was looked at in reference to the minimal stent area within the left main stem, the patients were split into tertiles, low, intermediate, and high. And what they were able to find was, in comparison to those patients who had a left main area of greater than 11 millimeters squared, there was a significant improvement in terms of hard endpoints of death, MI, stroke, all-cause death, myocardial infarction, and stent thrombosis. So when you're trying to achieve areas in the left main stem, you should probably be aiming for areas of greater than 11 millimeters squared. And this is exactly what we did with our gentleman. So this is the same case again. We performed IVUS at the end of the procedure, and you can see that we've achieved an area of greater than 12.6 millimeters squared in the left main stem. The LAD area was over 7 millimeters squared, and at the polygon of confluence, the area was just under 8.5 millimeters squared. So just to conclude, I've shown you that IVUS, and hopefully convince you that IVUS offers additional value to coronary angiography, which often underestimates coronary artery disease. The recommendations for use of IVUS recommend that it should be used to optimize stents in patients, and also particularly in left main stem disease. And I've shared a couple of illustrative cases where we've used IVUS both in the pre-stenting, peri-stenting, and post-stenting arena to try and optimize our stents. Both of those patients did very well. So thank you once again.